Hello, good evening to everyone. So today we are going to see care of comatose patient. So let us see the introduction first. The brain, it requires a constant supply of oxygenated blood and glucose to function, as we all know. So if there is interruption of this supply, there will be a cause of loss of consciousness, and this will happen within few seconds, and which will result in permanent damage in minutes. So let us understand the meaning of consciousness. It is basically a state of awareness of oneself and the surrounding, or you can also say it is the ability to perceive sensory stimuli and respond appropriately to them. Just in case where we are touching a hot pan and we remove our hand. So this is a perfect how an individual is able to perceive these stimuli. So, what is unconsciousness then? So, it is an abnormal state, obviously, and in this, the person or a patient is unarousable and is unresponsive. And in this, coma is a deepest state of unconsciousness. So, unconsciousness is a symptom rather than a disease. So, we cannot say a person is suffering from unconsciousness, but it is one of the symptoms. And the degree of unconsciousness, it can vary in length and severity. For example, if it's for a brief period of time, fainting can be one of the reason, or fainting is one of the briefest part of unconsciousness, but it happens for a longer period of time, then it is called as deep coma. So, what are the level of consciousness? In which cases it happens? It can happen in excitatory unconsciousness. That is basically um, during a procedure, surgical procedure, and then stupor, fainting, somnolent, and coma, and lastly in vegetative state. So in vegetative state, of course, there is brain dead, due to which the person is unarousable. So let us understand what coma means. Coma, it comes from a Greek word which means deep sleep. So it is a deep state unconsciousness in which a person cannot be awakened. The person fails to respond normally to painful stimuli, even lighter sound, and there is a lack of normal wake and sleep cycle, and the person is not able to initiate voluntary action on his or her own. So the anatomy of consciousness, it starts with ascending reticular activating system, also known as ARAS. So this particular system, it activates system of the upper brainstem, thalamus, and this particular system, it determines the level of arousal. And what happens is, in the cerebral hemisphere, and the interaction between the functional areas in the cerebral hemisphere, it will determine the intellectual and emotional functioning. And there is an interaction between cerebral hemisphere and activating system. So in this, the ascending RAS from the lower bottle of the pons to the ventromedial thalamus, and the cell of origin of the system occupy a paramedian area in the system. So we have to understand this particular system, ascending reticular activating system, so as to know how unconsciousness is hampered. So, in this pathophysiology, we'll try to understand what happens is there is damage to the brain or skull due to any reason. So, this can lead to inflammation, edema, and hemorrhage, which in turn leads to increase in the ICP. So, ICP here is intracranial pressure, and this can lead to cerebral tissue and diffuse damage. And here is the main problem: the RAS, which was supposed to be functioning, gets blocked due to various reasons that I've already explained, and this will eventually lead to unconsciousness. So, this is the basic pathology, and there can be various causes leading to this pathology. It is further divided into structural or surgical, metabolic or medical. So in we'll see one by one. In structural or surgical, it can be because of trauma, it can be because of epidural or subdural hematoma, there can be brain contusion, it can be because of hydrocephalus, it can be because of stroke, it can be because of tumor. And when we talk about metabolical metabolic and medical causes, it can be because of one of the reasons can be cardiac arrest, and it can be because of hypotension, it can be because of something like meningitis and encephalitis. It can either be because of hypo or hyperglycemia, it can be because of hyponatremia, it can be also because of drug or alcohol overdose, poisoning, and hepatic encephalopathy. Then, what would be the various signs and symptoms? So, since the person is unconscious, so the first thing that happens is unresponsiveness. The person is not, you're not able to arouse the patient. The person, of course, will be unaware of the surrounding, unable to open the eye, pupil is not responding to light. There can be irregular breathing. The person is not able to speak or move part, and there can be incontinence also. And the GCS score here, whenever we talk about coma patient or neuro patient, we always need to uh, be sure of the GCS, or we have to see the GCS of the person. So GCS score will range from 3 to 8 in between. So the effects of altered loss of consciousness of coma can be because full recovery with no long-term residual effect. There can be recovery with residual damage, learning deficit, emotional difficulties, and impaired judgment. And there can also be persistent vegetative state, cerebral death, or brain death. Then, what are the various diagnoses? So, in diagnosis, we have X-ray, skull can be done, MRI can be done to assess the tumors, vascular abnormality, and intracranial bleed. CT scan is also recommended for to assess if there is cerebral edema, infarction, hydrocephalus, or midline shift. Then lumbar puncture to see if there is any meningitis, cerebral meningitis. For this, CSF, cerebrospinal fluid evaluation, can be done. Then PET scan can be done, that is positron emission tomography, EEG to assess the electrical activity of the cerebral cortex, and a few of the blood tests like CBC, complete blood count, then LFT, RFT, and ABG can be done. So, how do we assess the patient then? So, assessment is purely based on history, first of all. A detailed history has to be taken from the patient or patient relative. Besides that, the other assessment can be done, neurological assessment, like assessing the Glasgow Coma Scale, the vital signs of the person, and also ascertaining the pupil size and reaction, and also doing the limb movement and tendon reflex, etc. can be done. So let us see the Glasgow Coma Scale, how it can be done. So in Glasgow Coma Scale, we have three component. That is eye movement, which ranges from 1 to 4, verbal response, which ranges from 1 to 5, and motor response, which ranges from 1 to 6. So I think this is well known to everyone only, but the main problem that happens in assessing the Glasgow Coma Scale is many of us we are really confused with how to assess the motor response in case of decorticate posturing and decerebrate posturing. So to make it more simpler, so when the arms are like C, when it is like this, it moves in towards the cord, then it is known as decorticate. And in case, so there will be flexion of the hand, but in case of decerebrate, so we can also remember decerebrate, E is there, so we can also remember it is E, and arms will be like here, so it can be a formation of E. So this is decerebrate. So this is because there is a problem between midbrain and pons, and if the person decorticate, that means there's problem with cervical spine tract or cerebral hemisphere. So GCS is further divided into mild, moderate, and severe. If the GCS in between 13 to 15, then and there is the chances of recovery is good, and if it's moderate, then it the scoring can be anywhere between 9 to 12, and severe is less than 3. That is when the patient goes into coma or deep coma. So these are the limitation. Although we do GCS scoring, but then there are certain limitation with the use of GCS scoring also. So if the patient has severe facial eye swelling or ptosis, then we are not able to assess the eye response. And the patient who's in deep coma with flaccid eye muscle will also not show response to stimulation. However, if the eyelids are drawn back to the eye, it may remain open also. So this is very different from spontaneous eye opening, and it must be recorded as none. So this is one of the limitation. The other limitation with verbal responses, if the patient is on endotracheal or tracheostomy tube, and hearing defect or speech defect may also alter patient's response. Return instruction may be used. So in case of the patient is in endotracheal tube or tracheostomy tube, we always mention it as VET in case of endotracheal and in tracheostomy, VGT. So in that way, we are able to know that the verbal response of the patient cannot be assessed. In case of motor response, there will be asymmetrical responses that indicates focal deficit. So it should be recorded. Example, if a patient localizes pain on his left side but flexes to pain on his right side, that means localizing response is recorded. It has to be recorded, and the patient has to explain the use of pain stimuli to the relatives also. And plain infliction may result in bruising also. So these are certain limitations. And to assess the pupils. So to assess the pupil, first we should know how does a normal pupil look like which it is round, regular pupil, equal in size, and it the normal pupil size varies in between 2 to 4 mm in bright light and 4 to 8 mm in darkness with physiological variation. Having said that, the pupillary light reflects the response to pupillary light reflex. It is easily tested component of a neurological exam of a comatose patient, which provides key information about brainstem integrity. So, observe the pupil size in ambient and dim light to check for anisocoria, and shine a bright light into one eye and then alternate between each eye, observing the reactivity of both pupils. So, pupil constrict to direct illumination, that is, direct response and illumination of the fellow eye. Consensual response, it is known as pupil dilates in the darkness. So, note if the pupils are briskly reactive, sluggish, or unresponsive. So, this will give us an idea of the pupillary reaction. Then, if there is inadequate miosis or mydriasis, there will be bilateral, small but reactive pupils which are non-specific. So, it may suggest a metabolic etiology or diencephalic lesion or the effects of the certain toxins or drug. And if there is anisocoria, that is unilateral mydriasis, that can be uncal herniation or any compressive lesion along the third nerve. And if there is unilateral small but reactive pupil, it can be suggestive of Horner syndrome, which is caused by damage to ipsilateral oculosympathetic pathway. So if it is abnormal reaction to light, then there can be failure to dilate in the dark, failure to constrict to light or accommodation, dissociation between direct and consensual reaction. So relative afferent pupillary defect can also be there. So there can be action accommodation reaction, there can be light near reflex dissociation. So when we assess the pupillary reaction, there can be many things suggestive the uh, of if there is any problem. And the assessment, when we are doing assessment nowadays, with the new update, beyond the GCS, the newer full outline of unresponsive, we can do 4 score, which is recommended, which has all the components which will help assess the status of the patient, which includes brainstem reflexes, visual tracking, and a respiratory pattern for a more detailed assessment of consciousness. So it also assesses in this 4 score, it has a quantitative pupillometry, early and serial evaluation, and it is also suggestive of targeted temperature management and fever prevention. And to see the non-convulsive status epilepticus early, EEG is suggested. Then we can do rehabilitation and chronic care for the patient, multimodal therapy using auditory, visual, tactile, and olfactory inputs for prolonged consciousness, or multidisciplinary approach. It is emphasized. So, besides that, individualized care target like CPP management can be done, and cognitive motor dissociation to see this early recognition can help with long-term outcomes. And the Curing Coma campaign is also one of the new initiative in which impaired bowel and bladder function can be seen, which will include focusing on discovery, clinical trial, and new treatment. So every year, 22nd March is celebrated as World Coma Day, which is to raise awareness and foster collaboration in neurocritical care. So medical management includes, first of all, the goal is to preserve brain function and to prevent further damage, which will include the management of blood pressure. We've already discussed about management of the temperature. The person would require ventilatory support, the management of fluid balance, oxygen therapy, and management of seizures. So, for this, anti-epileptics, sedatives, and paralytic agents can also be used. So, treating increased ICP for this, you can give mannitol, corticosteroid. The management of temperature regulation for this, ice pack, rapid spending, antibiotic, NSAID can be used. For the management of elimination, laxative can be used. And management of nutrition, total reparative nutrition and RTC are usually recommended. And of course, if the patient is lying for a long period of time, there should be provision for DVT, in thrombosis prophylaxis as well. The surgery, if at all, if it is necessary, it needs to be done, which includes craniotomy, which is skull upon bone flap, which is kept in the abdomen. Craniotomy can be done, cranioplasty, and bone hole is recommended. Then complication, there can be various complication of immobility starting from skin. The patient can develop pressure sore and laceration. In respiratory system, hypostatic pneumonia can develop, pulmonary embolism can develop. So it's in cardiovascular complication, event thrombosis, postural hypertension, thromboembolism can develop, and in GI system, paralytic ileus, constipation, distension, urological can have urinary tract infection, formation of stone. In musculoskeletal system, there can be contracture, osteoporosis, dystrophy or weakness, and neurological could drop along with other conditions. Now, coming to nursing management, the goal of nursing care should be to maintain the patent airway, to maintain adequate cerebral perfusion, the person should remain normothermic, and positioning of the patient, endotracheal tube or tracheostomy care has to be given, chest physiotherapy, elevating the head end of the bed, because the patient has more chances of increased ICP, the suctioning of the patient as and when required. The patient has to be free from pain, discomfort, and infection, and attain maximum cognitive, motor, and sensory function. So, to monitor the conscious level as impairment may complicate the existing condition and may cause complication and further deterioration. Of course, the monitoring of the Glasgow Coma Scale for initial and continuing assessment should be done. And there's one research input which talks about taking care experiences of improved comatose patients with traumatic brain injury and their families. It was conducted to describe the taking care experience of coma patient and their families during and after treatment. It was a qualitative content analysis. This patient or the participant in the study were improved TBI patient and their families. They were selected purposefully, and the method consisted of 16 interviews with 14 participants. Data were analyzed using yellow and uh, uh, Guards Convention Content Analysis Guideline with Max QDA software version 10, and it showed the four main themes and 8 categories. Themes included crisis, comprehension, support, communication, and unprofessional care. So the potential nursing diagnosis for a patient, comatose patient, can be ineffective airway clearance because the patient is in line for a longer period of time. So the person may develop ineffective airway clearance, ineffective cerebral tissue tissue perfusion. There can be risk of increased intracranial pressure. There can be imbalanced fluid volume, impaired skin integrity. The person, the cause is unconscious. There can be self-care deficit, imbalanced nutrition, and incontinence related to either bowel or bladder. So, how do we take care of this aspect, various aspects? So, for ineffective airway clearance, we can maintain a patent airway by assessing your breath sound every second hourly. ABG can be done to interpret depth and to determine the degree of oxygenation provided by the ventilator or by the oxygen. Assess for cough and swallow reflexes. Use an oral artificial airway to maintain patency. Tracheostomy or endotracheal intubation and mechanical ventilation may be necessary. It has to be done need based. It should be done, and also, we have to see to prevent airway obstruction. So, the position on alternate side, 2 to 4 hours to prevent secretion accumulating in the airway on one side. So, this can be need based if and when it is required. The patient can be positioned. The patient has to maintain neck in a neutral position, and oropharyngeal suctioning can be done to aspirate secretion. If there is facial palsy or hemiparalysis, then the affected side must be kept the uppermost. Chest percussion and postural drainage may be prescribed to assist in the removal of tenacious secretion. Dentures, if at all, if it's there, the assessment should be done if there is any dangers, and it has to be removed because it can fall back and the patient can aspirate it. So it can lead to many complications. Nasal and oral care is provided to keep the upper airway free of accumulation of secretion and debris. And so suctioning, either open or closed suctioning, can be done as per the policy of the institute. And for tracheostomy care, it has to be done according to the need assessment. Then the second diagnosis is ineffective cerebral tissue perfusion. So the person has to be continuously monitored for physiological parameters, vital signs, PCS, SpO2 level, and EVG of the patient. Vital signs, if there is increased temperature, it has to be maintained, moderation has to be done. Head elevation of 30-degree neutral position maintained to facilitate venous drainage has to be done. The patient has to reduce agitation. So for that, sedation can be done. Reduce cerebral edema. So medication can be given, and this generally peaks within 72 hours after trauma and it subsides gradually. Also, schedule care so that the harsh activity are not grouped together with breaks between care and recovery. Talk softly and limit touch and stimulation to the patient. Administer laxative, antidepressant, and antiemetics as been ordered by the physician. Manage or maintain temperature with antipyretics and cooling measure. Prevent seizure with ordered dilating, and administer mannitol, sorry, 25 to 50 gram IV bolus if ICP is more than 20 as prescribed. So if there is risk for increased ICP, the GCS has to be assessed. Assess the sign of increased ICP. Head elevation has to be done. Pre-oxygenate the patient before suctioning, and pass the catheter limit to 10 seconds with appropriate sedation to limit the rise in increased blood pressure. Insertion of an oral airway to suction the secretion, which is recommended, and breath sound can also be assessed every second hourly. So we were talking about signs of increased ICP. What happens if there is increased ICP, and how do we know that the person has increased ICP? The person will be restless. Complaints of headache will be there. There will be pupillary changes that we need to know how to do the assessment, and assessment has to be done every hourly. If there is signs of increased ICP, there can be respiratory irregularity, there can be widening pulse pressure, hypertension, and bradycardia. So for impaired skin integrity, the nurse should provide intervention for all self-care, including bathing, hearing, skin care, and nail care. The nurse should be able to assist the client in the activities of daily living. Frequent back care should be provided. Proper devices should be used. Positions should be changed as and when necessary. Special mattresses or airway to be used as per the condition of the patient. The skin condition of the patient, it has to be assessed every time. Adequate nutrition and hydration status should be maintained. Patient nails, if at all, if it's long, it has to be trimmed. The corner should be kept moist and filling methyl cellulose. Protect eye shield Protective eye shield can be applied with the eyelids closed with adhesive stripe if the corneal reflex is absent. It happens in most of the unconscious patient, and these measures it prevents corneal abrasion and irritation. Inspect the oral cavity, keep the lips coated. If the lips is coated, it has to be moisturized. Frequent oral hygiene can be done every 4 hourly or as and when required. Nasal passages may get occluded so that they may be cleaned with a cotton tip applicated. So assessing the skin hygiene, bacteria, prevention of bed sore. For this, you can do the assessment of the development of bed sore, if any, and then you can take care so that the patient does not develop bed sore. If the bed sore is there, we should be seeing that the patient does not develop further complication. Positioning has to be maintained. Comfort devices have to be given. Nutrition has to be assessed. In positioning, we have to see if the patient has soiled the linen, it has to be changed. Do not wait for second hourly position change. Eye care, we've already discussed. It has to be observed. Pupil dilation has to be seen. If there is, if the condition, if the eye hygiene is not maintained, cleanliness has to be done. Eye drop has to be instilled, and if at all, if it's required, eye pad has to be can also be kept. So in skin only there can be risk for contractures in extremities, maintain the extremity in functional position for providing support, remove the supportive devices every 4 hours for passive exercises and skin care. Foot support should also be provided to avoid foot drop. So prevention of deep vein thrombosis can be done, prevention of contractures and prevention of foot drop. So proper positioning, this we already discussed. Lateral position in the pillow to maintain head in a neutral position has to be done. Upper arm position on the pillow to maintain shoulder alignment. Upper leg supported on the pillow to maintain alignment of the hip. Change position to lie on alternate side every second to 4 hourly or as and when required. And for hemiplegia, maintaining correct positioning enables situation. So protecting the client is very important. We have to see the safety of the client for which the side rail has to be put up. We have to take care to avoid any injury or fall, protect from external sources of heat, avoid oversedation, and assess for need if there is any need to restrain the patient with the consent of the patient or the patient attendant. The next diagnosis is imbalanced fluid and imbalanced nutrition or fluid and electrolyte balance. Sorry, there's a mistake. It is imbalanced fluid and electrolyte. So for this, intake and output chart has to be monitored. Daily weight should be taken to see whether there is gain. Of course, there will not be gain, there will be loss in usage. Just to see the progress, it has to be done. Assess and document symptoms that may indicate fluid volume overload or deficient. Diuretics may be prescribed to correct fluid overload or reduce edema. And overhydration or intravenous fluid with glucose are always avoided in comatose patient as cerebral edema may follow. Sorry, it is overhydration. In case of self-care deficit, the patient has to be assisted on his activity of daily living. So attend to the hygiene needs of the unconscious patient. It should never become ritualistic, and despite the patient's lack of awareness, dignity should not be compromised, and involving the patient attendant, patient relative in the care will be more beneficial when the patient goes out of the hospital, even they are able to take care of the patient. They know how to do that. Then for oral care, it is very, very important. It has to be assessed. Then chlorhexidine-based solution can be used to take care. It should be removed. The injury if it's there, it has to be removed. Protection of gingiva is important. Imbalanced nutrition, diet prescribed nutrition based on individual requirements, specifically to meet energy needs, tissue repair fluid loss to maintain basic life function. So in nutrition, if total parenteral nutrition is recommended, it can be given, and the patient has to be continuously monitored. So this usually happens for 24 hours. So the patient should also be monitored for his glucose. RBS has to be monitored and has to be documented. If there is any problem, it has to be informed to the physician as soon as possible. Enteral feeding via nasogastric, nasojejunal, or peg tube is given, and IV fluid maximum 72 hours it is given. So methods of total parenteral nutrition, it is considered for prolonged unconsciousness and intravenous fluids are administered for the comatose patient as fluid intake is restricted and glucose is avoided. So in case of risk for injury, this we've already discussed, side rails must be kept up, severe precaution must be taken, adequate support to limbs and head must be given when moving and turning patient, protect from external source of injury. Impaired bowel and bladder function, assess for constipation and bladder distension, auscultate for bowel sound, stool softener or laxative may be given, bladder catheterization may be done, meticulous catheter care must be done so that the patient does not get urinary tract infection. So, patient has to they have to be assessed for fiber-rich diet, assessed for bladder distension, bladder catheterization, and catheter care. The component of psychological support is very, very important. So for patient, we can encourage sensory stimulation. We can talk to the patient. We can see if the patient is able to perceive pain, if the patient is able to understand, and we can play music, radio, CD, TV for the patient, reading a book for the patient, and family. For family, we have to involve the family in the patient care. We have to be empathetic towards the family and understand their problem also. So this was all about the assessment of a comatose patient and the role of the nurses in taking care of the patient. I hope that it will be useful for all of you. Thank you so much. Before we conclude, these are my references.